everybody. Welcome back. We are on day 5 of the CCIH 2020 virtual conference. And this morning was so good. Well, it was morning for me. Whatever time zone it was for you. I know that between people on the west coast of Africa and the east coast of the US, the east coast of the US and the west coast of Africa, as well as those around the world in London, Pakistan, Philippines, Sri Lanka, we had people from all over that are participating, and so trying to find a time of day that works for everyone to join in is no easy task. So the conference organizers have been putting different days at different times, trying to make it work for as many people as possible. So for me, I have to be honest, that's meant some pretty early mornings, but it's been good. I've been enjoying getting to participate in the conversations that have been taking place online during the discussions, as well as online in the comments and social media after the fact. So I definitely miss getting to be part of the in-person experience, but it's been great being able to have those interactive dialogues. So I will say, out of the sessions that we've had so far, this was probably one of my favorites. What I really liked about it was that we didn't spend too much time on a more formal presentation. We really jumped into questions pretty early on. Even the introductions included some interesting stories, and then we were really just able to hear from the speakers on topics that were of interest to those that participated in the panel. So we had a number of questions, and they really just spent most of the time answering those questions. It was a very interesting discussion and really well moderated and all of that. So I would definitely recommend checking it out. The link is down in the comments. And if you are interested in signing up for the rest of the conference, it's free. So jump in. There's another 4.5 weeks to go, so you've got plenty of time. But I just want to let you go ahead and hear a few stories. This was Dr. Ann Peterson and Dr. Peter Yerboa, and both just really a wealth of experience. I would love to just sit down and spend a whole hour interviewing either one of them themselves, but getting to have both of them was really quite a treat today, and we really got to talk about a lot of interesting topics. So without further ado, let's get started here with this is Anne talking about the experience with Hurricane Maria and the impact of health facility readiness. So this session, there was a lot of discussion around what does health facility readiness look like in different contexts, lots of great examples, as well as I think, we have to start wrestling with some of the challenges around what does that look like in a low resource context. So let's hear from Anne.
I just want to mention an example in a response from my time in Puerto Rico responding to Hurricane Maria. I was there within the first day, and it was incredibly dramatic to go down to the southern part of the island, which was very hard hit. And there was one health facility that was up and functioning within hours of when the hurricane hit. They had their doors open. They were seeing hundreds of patients. They had electricity because they made generators. They had a preparedness plan, which was in place, which was practiced. They'd gone through it before the hurricane hit, and they were functioning. And 2 miles away, one of the, referral hospitals was closed down. So preparedness can make a huge difference. And Peter mentioned fear. There has been so much fear, almost fear driving the epidemic as well as everything else. What preparedness does for people, so on a personal level, but also for a health center, is it gives you back some of the control. It gives you something you can do to tamp down the fear, to have an active response so that you can go to work as a nurse or a doctor or an ancillary personnel and know that you're going to be protected in providing care for your patients. So it changes both the attitude and the functionality if you have gone through your preparedness.
So I appreciated that example. Hurricane Maria hit Puerto Rico during a time when really it opened a lot of eyes to what could happen when you had that kind of level of disaster, and where some places were really prepared and other parts of Puerto Rico that weren't as prepared. So that was good and good reminder. I think there's been a lot of discussion around fear and especially when it comes to holistic health. Part of that is addressing the fear and the related challenges. So Dr. Peter talked about the fact that in some of the regions they were looking at, they'd only had 4 COVID deaths, but they'd had 40 in one community related to meningitis. And so for that community, although there was a global interest in COVID, their community should have actually probably been paying more attention to that meningitis outbreak at that particular moment. And then touched on some of the Ebola lessons learned and how that could be applied, and especially at the community-based response level. And then Peter was talking about how Sierra Leone has not been overwhelmed nearly as much as you would think, given the existing health ecosystem, but really how the community had responded, how the community was mobilized, how they understood the importance of community response and of risk management, and were really a lot more willing to engage in that than they would have been pre-Ebola. And I just want to share with you now one of the kind of lessons learned that came out of that with regard to the balance of supplies versus training and that whole question. So let's come back over here. Oh, sorry, guys. 1 second here.
To be some benefit. On PPE itself, I think it has been a huge focus, and I'll say partly completely rightfully, because as Peter said earlier, the healthcare worker is essential to responding to COVID, to being able to care both for COVID and non-COVID patients. And so we do need to protect them. We do need them to continue to come to work and not be afraid that they aren't protected. I will say that for our organization, we usually get donated medicines and medical supplies and then distribute them to our partners around the world, more than 92 countries. And we get some PPE, but not very much. This is the first time we have done very large scale, millions of dollars worth of buying of PPE, and spent a lot of time, like you probably have, trying to find the right place, the good quality, the tested and approved, and then trying to make the hard decisions about where does it go first.
And so on that question of where does it go first, that's actually one that has come up, and that I really felt like Dr. Peter Yaboa had a very interesting point about this that I wanted to share with you, because he brings up the question of the rural health centers. And I want to go ahead and let him share a little bit of what he was talking about, and then I want to expand on this one a little bit further.
How do you distribute? Of course, we develop a criteria. Equitable allocation in this circumstance is very important. And it is always easier to look at the epicenters of COVID. And normally they're in the cities. And that is also about some neglect of the rural areas that may be asymptomatic carriers, and they may even probably have a spike later on. So in our experience, whatever PPEs we had a delicate balancing act. Where are the epicenters? Which hospitals have reported, have confirmed cases? That is one. Which facilities are in the peripheral area that have not had any confirmed case, and that we could provide PPEs to ensure that they prevent. Remember, most or 90% of all the confirmed cases ever passed through the lower centers, the lower levels, the clinics, the health centers. Before they were suspected, they became probable, and then they were confirmed over there. So we looked at equitable distribution of PPEs within the epicenters and also within the rural areas, where capacity for even testing, the PCR machines are not there, the gene expert machines are not there, they don't have the cartridges and the rest. So they may be, unintended, victims of our institutional neglect. So in distributing PPEs, number of active cases, important criterion, and yet the need also to prevent the transmission in areas without confirmed cases were also necessary. This is an ethical issue worth considering. But
so this is a really, really important point that Dr. Yeboah brings up, and it's one that I think has not been talked about enough. When it comes to the testing that is being done. So for those of you who have already lived through a lot of this with COVID-19, this is probably something you're already familiar with. For those of you who maybe your country is still about to experience this or has mostly been able to avoid it so far, the testing that is done for COVID-19 requires RNA sequencing, which means that it requires PCR machines, which really until fairly recently were not readily available even in the most advanced healthcare systems. And so for many countries around the world, there are only a few places where you can actually go get this test done. And so what that means is that you have a number of places who have suspected cases, but they can't actually confirm that the case is there. The person goes to the major city, to the major hospital, they get tested, and that is where then the case is confirmed. So if you only look at confirmed cases, you're going to see a few major hospitals that are the places that are doing all of the testing that are going to say, yep, this is where all the cases are. But the reality is that there are going to be at least some of those people, if not a majority of those people, that are actually coming from the more rural areas. So it's very important when you consider allocation of resources in response to a pandemic like this, that you look at what kind of testing is being done and where is it being done to make sure that you are adequately representing what the needs really are. And so this is something that as Dr. Peter Yeboah runs an entire regional network, right? He is not only responsible for Ghana, but for an entire association across Africa. This is a conversation that's come up multiple times. It's come up in the conversations we've had with colleagues, but really being able to answer this question of how does this work across the board and how do we know the places that are being impacted? And we can't only look to the testing that's being done as that answer. So this was a really interesting conversation. Those were just a few little tidbits of many questions that were asked and answered. And I really encourage you, please go watch the whole video and join us for tomorrow for day 6. I will be getting up even earlier tomorrow to join in and watch that webinar. And I'll be telling you about it tomorrow evening. Thanks.